all of you to this session on electrophysiology. So I should thank all of you to, so you have tried your best enough to make it to the hall, though it's a morning session. So it's my privilege to invite all my chairpersons, so they need no introduction. So I welcome Dr. Subhadra Jalali ma'am on the stage. So as we all know, she's done a lot of work in ROP, and she's very passionate about electrophysiology and also inherited retinal dystrophy. In fact, she was the key person who was involved in who brought out the CME series on electrophysiology in AOS. So welcome, ma'am. So, Parveen Singh. Parveen is on our way. And I would like to invite Dr. Tapas Ranjan Padi. So he's the head of Retina at Ali Prasad Bhubaneswar. So he has also a special interest in electrophysiology and he has published many papers on electroculogram. So we are happy to have you, sir. Please take the seat. And we have Professor Anand Bandari over here. So he is the head of the department MS Ramaya. Okay, and he is also founder executive committee member of Untitled Chapter of AIOC2022 and is also CEO of Bangalore Eye Hospital and Retina Center. So we welcome you, sir. Please have it. So without wasting much time, we'll go on to our first talk. So first talk is from Subhadra Jalali ma'am. So she'll be talking on physiologic origin of electroretinogram. Over to you, ma'am.
You won't stop me from leaving if you will leave, but come to the front, then it will look nice and you'll understand better. Anyway, so I'm going to speak a little bit about physiological origins of the ERG. Will make it very simple so that it's just understandable to you, like what we should know about the physiology of this. I'm not going to all the technical details. I think the first thing that I like to tell my students is that whenever you're looking at the electrophysiology outputs, you should have a good idea of how the waveforms look like. Because the machine will, write down something, it will put some data there, but the first thing is to eyeball the waveforms. And as you see, that these waveforms are very typical, this is for typical normal, and they have very typical characteristics, or typical shapes. Now the first thing you need to see what is the scale. So you can see here, this is the scale. Iska cursor, I think there is a cursor. Okay, this one. Okay. So you can see this is the scale. Now you see here it is 22, so this is 200 microvolts per division. Okay, just like your Google map. So it's some places closer if you reduce the screen, but the actual distance may be more. So it is 200 microvolt, that means it's almost 2 millivolts. So it's a big output. Whereas if you see the lower one, which is the pattern ERG, it is 1 microvolt per division. So you should not directly look at the waves and say, no, this is bada, this is chota. So you have to look at the scales, because if the waveform is very small, then the technician should increase the scale so that you can look at it properly. And if the wave is very big and you keep the same scale, then the wave will go out of the paper or out of your screen. So obviously the scale will go down. So the ERG is a big wave. It's 6 millivolts normally. It's the biggest wave. Whereas the pattern ERG is very small. It's 7 to 8 microvolts, so the divisions are 1 microvolt. Whereas the VP that we are seeing, it is 2 microvolts per division. And for the combined retinal response, which is the maximum response of the rods, cones together, the full response of the eye, that is about 20 microvolts per division, so that will be about 400 to 500 microvolts. So whenever you get any output, so first you should make sure that if somebody has written ERG or EAG or VP, it looks like what it is supposed to look like. If it doesn't look like this, then it is noise. The machine will still give you some output, but it will be noise. It is not the true wave. Okay? And as I said, we look at the... Okay. Now, the second concept is that in the eye, there is only one cell which can respond to light. So the visual electrophysiology depends on putting a flash of light on the eye and then the eye responding with an electrical signal. That's how we start the vision signaling from the eye to the brain. So one has to remember that for up to 1850 or something like that, the concept of this electrical signal ganglion lens. There was no concept that vision comes from the visual cycle, or there is a retina, or there are electrical signals. So it took almost 100 years for the scientists to get all this data and explain to the people that actually how vision happens is that a photon of light falls on the retina, and in the retina there are many cells, there are 10 layers of retina. The only cell which responds to light is photoreceptor, that is rods and cones. So they will generate the signal, and that signal will activate the RPE on one side, and it will activate the bipolar cells, the amacrine cells, the horizontal cells, and then on the ganglion cells, and then on the optic nerve pathways. And then it will go to the visual cortex, and from visual cortex again that message will spread to the higher areas of visual processing, temporal lobe, parietal lobe, and then the action will start. So we should understand that if the photoreceptor is not functioning, you cannot use these tests to check is the optic nerve functioning or not, or is the RP functioning or not. Okay, is the macula functioning or not? So the photoreceptors of the macula or the peripheral retina, depending on which test you are doing, must be functional for us to see the cascade down. If this is not there, let's say the photoreceptors are not there, then we have to use some alternate method of checking is the optic nerve functioning or not, or is the ganglion cell functioning or not, and there are some alternate methods, but we are not going to that. So the retina is like a mathematical model. It is in three different layers. There is the outer retina, which is the RPE and the photoreceptors, and then there is an inner retina, which is the bipolar cells and all the other interconnecting neurons, and then to the ganglion cells. So the function of the retinal pigment epithelium in the clinic we study by EAG. Again, it is a light-mediated response. And again I am telling that it doesn't stimulate, the light doesn't stimulate the RP. It cannot stimulate the RP. It will stimulate the photoreceptor, and after stimulating the photoreceptor there will be change in the interphotoreceptor and RP ions, and so the EAG will get generated, and then of course the person who is going to speak on EAG will talk about that. And on the other side, it's the so the RP of course we study with EAG. Now the photoreceptor function itself we study with the A-ray. Okay, so when they talk about EAG they will tell you about A-ray, B-ray. But just to remember that the photoreceptor function is A-ray. So sometimes people are confused, like A-ray is from rods, B-ray is from cones. No, the A-ray is from the rods and cones. Both, if you do the test in dark, the A-ray will come from rods. If you do it in bright light, it will come from the cones. And of course you can have the both also there. And then the inner retina. So any disease which affects the inner retina, that is the nuclear cells, the bipolar cells, will affect the B-ray. Okay, so in diseases where the inner retina is involved, the B-ray will go away. The A-ray will be there, but there will be no B-ray, and we call that as a negative EAG. So that will be like retinostysing, retinopathy occlusion, some of the drug toxicities. So, whenever there is a disease or a genetic mutation in the bipolar cell like CSMB. So in those cases you will get the A-ray because the photoreceptor is fired, but the B-ray will not be there. The macular photoreceptors will be checked by pattern EAG and multifocal EAG, so they will talk about it. And from optic nerve to chiasma, it will be checked by BP. The good thing is that all these protocols are available freely on the ISA website, which is the International Society for Clinical Electrophysiology and Vision, and you can go through there whenever you want. I am not going into all those details. I am just going to stick to the physiology. And so when we are doing the visual electrophysiology, as I said, it's just starting with a single light. You put a light on the eye, and it is giving some signal, and you are picking up that signal. But over a period of time, last 50 years, there has been a lot of advancements in the clinical electrophysiology, and here now we have various tests which basically define our understanding. So there is a global response, that the whole retina is responding. Now we can have local response from the macula, from the fovea, from the periphobia, paraphobia, so whichever area we want to stimulate and get response. And we can have multifactor responses, we can have chromatic, like different colored lights. Normally we were using white lights, now people have used orange lights, green lights. So what will happen to the cells when we give those lights? And as I said, electroelectrogram usually light-based test, but if the photoreceptors are not functioning, the EAG can be very, very studied by giving a bottle of beer, or giving astazolamide, or giving mannitol. So you can have other chemicals. You're very happy if you say, I want to be a test person for this test, get a bottle of beer. And so there are non-light mediated tests also, which we are not talking now, and of course there are various methods to do. So now coming to the actual physiology, so flash ERG, which is what we are talking about, that when you put a light, there is a diffuse electrical response from all these neural cells and some of the non-neural cells like Muller cells, other cells within the retina, to full field illumination. So obviously we want the whole retina to be illuminated so that all the cells will start firing, and the firing will start from the photoreceptors. So what happens when the light falls on the retina? So basically this is a light-induced change in the transmembrane movement of ions. Mostly it is to do with sodium and potassium. So I will explain a little more details. And the cells get hyperpolarized. That is, they become more negative. So what is happening? Let's see. So this is the retina acts like a battery. It acts like a battery which has a negative charge and a positive charge, and the whole thing will come and you will get a potential. Okay, so there are ions there. There are sodium, potassium, and also there is calcium, chloride, and bicarbonate. You know, if you give Dimox, the bicarbonate pump will work. So the ERG will change. The ERG will change. If patient is having digoxin or patient is on dialysis, your ERG can change because basically it's the ion. So what will happen? That normally there is a gated channels. You know, most of our body cells, neuron cells, they have a gated channel. So they will allow certain ions to go in, certain ions to come out. Okay. So normally inside the cells, the ions are in such a situation that they are more negative. So the intracellular space of these photoreceptors is negative as compared to the outside. So that creates a standing potential. So even if you don't do anything, the eye has a standing potential. It means there is an electrical battery there already ready. So what will happen when we put a photon of light on? So these are just to show you, the current will start from there. So photon of light is basically an electromagnetic energy. It will interact with the redopsin. So redopsin is in the, it is in the rods. So this redopsin, the opsin part of it, it will start having a very rapid. So the moment you put light, you see, it's so fast signal. So this opsin part of the redopsin, it will alter chemical properties, means the bicarbonate, the sodium, potassium, they will start changing. And this induces three molecules. So this will affect three molecules. The first is transducin, which will then activate phosphodiesterase, which then breaks the CGMP, that is the cyclic GMP, and ultimately it will lead to hyperpolarization of the cells. Okay, so these are three four molecules. What you should know about this is, phosphodiesterase, it is inhibited by Viagra. So will giving Viagra change the ERG? So things like that. Or if patient has a phosphodiesterase enzyme deficiency, will they get more retinal dystrophy with Viagra? So these three molecules, and we told only three molecules, transducin, via phosphodiesterase, and then there is a glutamate. So most important is that this potential of the membrane will become negative. So there will be hyperpolarization of cell, which is very opposite of what happens in normal neurons. Normal neurons, they have an action potential. There is a spike. The moment you start some activity or you stimulate a nerve, there will be an action potential. Here there is no action potential. Here, because of this chemical change, there is a hyperpolarization of the cell. And this hyperpolarization will lead to release of the neurotransmitter, that is glutamate. Okay, and so there will be a change in the voltage. It's a battery, you change some chemicals there, so the voltage will change, and that change you pick up on your ERG. So actually, as I said, the rods and cones don't produce an action potential like other neurons in the body. In the dark, what happens is normally the glutamate is released by these cells because of the normal cycle. There is a lot of glutamate there, and that is inhibiting these cells from firing. And all the other neurons, they are not firing normally. Only the photoreceptors are releasing this glutamate, so there is an inhibition. So normally our retina is under inhibition. So when they get hyperpolarized, the glutamate starts going down, so this double negative, so the cells get released. So now they will start firing. They are now ready to fire. Okay, so obviously because this is a physiological system, so it is already there, and the light on that retina is changing the physiology. All the physiology parameters will influence the baseline or the normal value. So the age, gender, then it's time, let me know. I don't want to overshoot the time. So any physiological parameters, like the size of the eye, the color of the choroid, they will all influence the ERG. So we'll just go through a few of them, like age. It is very important to know that in the newborn you may not get an ERG. Although so many times patient, somebody has referred a 2 months, 3 months, somebody has done ERG and ERG is not there, and they tell the parent child is blind. No, the child may take some time to develop that ERG. So it takes 6 months to 1 year. So if you do ERG in a very small child and you get a good ERG, then that is good news. If you don't get an ERG or an EP, it doesn't mean child is blind. They will still develop over next 6 months to 1 year. Okay, so this is just an example of why we should know, that age affects it. So saying that with older age, the pupil VCT may be becoming different, or the lens may be getting sclerosed, or maybe actual photoreceptor degeneration is there, so whatever. So ultimately there will be a 100 microvolt difference or 50 microvolt difference between an old patient and a young patient. So you need to have normative data every decade wise in the older people for you to compare is this normal or not. The good thing about electrophysiology is that if there's a disease, then these things don't change little. Means if normal is 400 and patient has a disease, it will not become 320 or 390. It will change massively. It will go down to 50 or 100. So the change is massive, especially in the ERG. So we don't have to look for nitty-gritty chemo. It's like you are weight is 60 and tomorrow it's 61. It doesn't mean you've gained 1 kg, right? So only if it goes to 65, then you say, okay, I'm really overweight. So same way here, there's a test, we test variability, and when the disease is there, it will be a massive change, and the whole waveform will change. Okay, so gender, women have smaller eyes, so they have higher amplitude. And same way with high myopia. This is very important for us because high myopes, we have so many high myopes and they get CSND or RP. So if you have 20 diopter myopia or 30 diopter myopia, then the ERG will be almost flat looking unless you change the scale. And you will misinterpret it as, RP or something else. Okay, so I'm just stopping here. So as I said, there's a test, we test variability, and all the physiological parameters will influence the ERG. And there's also diurnal variation, but for due to the clinical effects, the diurnal variation is not important, but if you are doing a research study, then just like your IOP diurnal variation, you need to do the test at the same time or within that time. Is my time over? Yes. Okay. So we'll stop here, and that was just to give a little basic of what is happening when we are doing the electrophysiology of the eye.
So thank you so much, ma'am. So thanks for making such a complex topic look very simple. So before going to the second talk, it gives me immense pleasure to introduce Dr. Parveen Sen. She's a senior consultant with the Retinal Department, Shankar Netralaya. So she is a reviewer for national and international journals. Her areas of interest include ROP, retinal imaging, pediatric retinal surgeries, and electrodiagnostics and inherited retinal disorders. So we welcome you, ma'am. So now we'll go to the second talk from Dr. Tapas Ranjan Padi. So we'll be speaking on testing protocols for ERG and EOG. Over to you, sir.
Very good morning, respected friends, and it's my pleasure and honor to be here. I thank the organizing committee in Pune, and directly will go to the testing protocols of electroretinogram EOG. The origins and the advanced protocols should be taken care of by other speakers. So this is how the protocol that we are following and need to be followed as per the ICET standards. The updated standard is in 2022 for the ERG. So this is how the term electroretinogram simply means that it's a full field or flash electroretinogram. So the stimulator is a Ganzfeld stimulator. The purpose is to stimulate the entire as much retina as possible with an external stimulation. The responses generated are recorded in basically two phases, one during the dark adapted phase and the light adapted phase. The electrodes used they are active, where the electrodes that picks up the signals, so that there can be various types of electrodes ranging from contact lens electrodes to the skin electrodes. When the electrodes are contact lens, the pickup of the responses, the amplitude is better, good, compared to skin electrodes that have the waves at a low amplitude. The other electrodes, as is shown here, can range from gyri electrode, DTL electrodes, and the skin electrodes. The active electrodes need to be placed near on the cornea or bulbar conjunctiva or skin close to the cornea. This is connected to a positive terminal. Then a reference electrode is used which is connected to a negative terminal, and the difference, so that there is a difference of potential that can be recorded. There is a ground electrode which can be placed either the skin on the forehead or near the mandible or just anterior to the ear. The patient preparations include usually for fulfill the electroretinogram, the subject need not be examined with a bright light source like indirect ophthalmoscopy, fluorescein angiogram, or any other examination that uses intense light. If this examination is done, then it requires the patient for an extended period where the patient needs to come to a normal illumination or the dark adapted period is extended. Normally the standards recommend 20 minutes of dark adaptation and 10 minutes of light adaptation. The fixation here, this the full-field ERG is a test where the cooperation is not that essential. Even those with nystagmus and poor cooperation also the responses can be collected. Now this is how the waves look like. Basically the A wave and B wave, they are analyzed in the terms of amplitude and time to peak. The amplitude is measured from the baseline to the height of the waves, that is the trough in case of A wave, and from the trough of A wave to the peak in case of B wave. The time to peak from the signal to the maximum response. So this is how a report looks like. We should know how to interpret these responses. There are 6 responses, and these responses need to be pronounced or analyzed in a standard way. So the protocol is to tell the responses in the terms of state of adaptation and the stimulus strength used. So the first one is 0.01 dark adapted ERG. That means the subject is in a dark adapted condition and the strength is used 0.01 candela second per meter square. The second and third both are similar, but they are dark adapted 30 ERG, the second one, and the third one is dark adapted 10 ERG. So here a brighter flash is used, so the cone contribution is relatively more. This is important for especially in conditions with hazy media or immature retina where you need a brighter stimulus. The fourth one, actually there is no test, it's just a filtration of the responses on the ascending limb of the B wave, and finally we have 2 responses in the light adapted condition, that is light adapted 30, and the last one is light adapted 30 but 30 hertz flicker, the light flickering at 30 hertz flicker. Both are for the cone system. They are not same, they are complementary to each other, because the last one targets the L and M cones, where the 30 ERG targets both L and S cones. So the reports need to be analyzed in terms of the demographic details, race, gender, people size, the electrodes used, the lab used. First, as Dr. S.J. described, when we look at the responses, we need to analyze that, see that whether they are conforming to the pattern that is expected. Are they reliable or just artifacts? Then individual responses need to be analyzed and compared with the normative standard. So the term normative standard is now replaced in the latest standard. This is termed as reference value. So it is true, every laboratory needs to provide the reference value and the individual waves need to be compared against that. Now finally the electrophysiologist remark. So the pediatric age group recurring, as is shown here, there is no standard protocol yet, but we need to know that how to record these babies. The most difficult one are those who are toddlers, like 2 to 4 years of age. Examining them, eliciting a response with a contact lens electrode is very difficult. However, with this device, with the steam electrode, now the examination of these babies in the awake stage has become easy, and one can get a good result, avoiding the sedation or general anesthesia, which can be risky and also can affect the responses. So clinical protocol for electrooculogram, that is in 2017, which is how the setup looks like. Here the subject, the electrodes are placed at the outer and inner canthi, and the subject makes excursions between the stimulus kept at 15 degree apart, that is around 30 degree. So 15 minutes in the dark and 15 minutes in the light adapted condition. So the testing is takes around 30 minutes to 45 minutes. In every minute, the eye movements are done for 10 seconds. So 10 seconds in 1 minute, then another 50 seconds patient takes rest, again 10 seconds in the next minute, again 10 seconds in the next minute. Similarly, 15 minutes in the dark, again 15 minutes in the light. So during this 15 minutes, the system averages the amplitude and it takes the wave. So we have 15 waves in the dark phase, 15 waves in the light phase, as we can see here. So this is the suckers. When you look at the report, the first important thing to look at how are the these square waves, that is peak and the trough, slowly reduce in amplitude to around, say, 10 to 15 minutes called as dark trough. Then again they go on increasing till they reach around 10 to 12 minutes called as light peak. So then after that one need to look at the wave, whether when these amplitudes are plotted, there should be a sinus wave like this. So now here it is important that if the machine, if you don't keep the cursor or adjust the trough around 10 to 15 minutes, and the light peak, the peak that comes in 7 to 10 minutes, sometimes one can get a erroneous result. You might be having a case with best disease, but if your cursor, the peak that you have taken is at 2 minutes, or another erroneous peak one has taken, then you can get a fallacious Arden ratio. So that is why both the waves, suckers, as well as the wave, the pattern, as well as the Arden ratio are important. So the light peak to dark trough ratio, the replacement term for the Arden ratio as per the latest standard should be around 1.7 to 4.3, and every lab need to have their own reference value. Now finally, this needs lots of cooperation, the test, and if you are not careful, sometimes you can get erroneous results. Say for example, this case you see that the electrodes, when they touch each other, can affect the result of the other side, so-called kissing electrodes. Normally they affect by less than 15%, so one need to be careful. So I stay here and can take questions about.
So thank you so much, sir. So are there any questions from the audience? Okay, so then I have a question for you, sir. So in your opinion, what do you think like the role of doing this electrophysiological test on the general anesthesia? What the CO fluorine and the use, do you think?
I would stop using that. So after we have got that retinal device, I don't remember when I did last, maybe 1 year ago. So when we did that time, the protocol that we used to do is like the handheld device we need to take to the OR. Now there we need to be careful to get adequate dark adaptation, because OR setup, we have lights, all these things. So we used to close all the lights. We also tried using a black umbrella, around on the cloth, black cloth, in addition to the dark adaptation to maximize the responses. And we used to get good results. Now here, mostly I used to do them in the pediatric age group. There I learned that we need to differentiate between extinguished responses and non-recordable responses. So the responses that we get depends on the stimulus strength that we are using. You may get a response recording that shows us the waves are flat. But if you use a higher intensity light source, then you can get some responses. So if you tell that there is no response from the retina is not functioning just by looking at one type of tracing, it might be wrong, because in babies the retina is requires a higher light stimulus. So if those which show extinguished responses, if you do at a higher strength, you may get some responses. So it is wise to tell them as non-recordable responses. And in fact, the last the protocol that we are doing, non-extended one, have closed eyelid ERGs. So babies, even if they close the eyelids in the awake stage, like they sleep off in the OPD, close the eyelids. If the red light with a higher strength, prolonged of light is used, we can get a response that we see in the...
I just want to add on that it's the anesthetic drug or the sedative drug which will influence the outcome of your ERG. So if you are going to do ERGs in children under GA for whatever reason, then you should have a standard protocol by the anesthetists, what drug they are giving, what they are not giving. The challenge is to get a normative data with that drug, because you need a normative data, because it's going to reduce your responses. So the best way to get normative data is possibly that those children who are getting NLD, syringe and probing, that you can dilate them and if you take a consent, and those children you can do ERG to get your normative response. Now, whatever protocol they use for syringe and probing, the anesthetic drug or sedative, whatever they use, then the same they should use for the electrophysiology. So that's way to do it.
One audience, please go ahead.
In the pediatric age group only, when pediatricians refer child has hypoxic ischemic encephalopathy, kindly do a VEP recordings, or the eye frequently moves. If it is not under anesthesia, the eye frequently moves, and like a retinal device or any other device, it is said that the pupil should be within the circle, in the reference circle. So how reliable are the responses, and how can we interpret them then?
So for the retinal, because the whole Ganzfeld is placed right around the eye, it is covering the whole eye. So if the child is opening the eye, it doesn't matter that because for flash ERG you don't need fixation. You only need to illuminate the whole retina. Okay. So even if the child doesn't fixate, has nystagmus, squint, or wherever, as long as the Ganzfeld is there and the pupil is well dilated, you will get the response, and it will be reliable.
In these group, many times we are not that much particular with exact amplitude, latencies. Mostly we need to have a qualitative idea, and that qualitative idea you can get by briefing the protocols also. There's a brief protocol. The momentarily the child looks at the fixation target, you can get a response there.
And sir, regarding what you said, increase the intensity of the stimulus, like till what level can we increase the stimulus?
Yeah, they have extended protocols like the Retinal that I use for closed lid. I went up to somewhere 50 prolongers. So each machine has that recommendation, what strength you need to use.
So in the ISO standard, there is something called a bright flash ERG. So they said do normal, and that bright flash is 6 log units light above the standard flash. So that is what we use.
And ma'am, since there might be a lot of ERG being done, like can you, is there any published literature of the standard data in the pediatric case group, ma'am?
It is there. It is there.
Is that retrieval device?
Yeah, it is there.
I said has, and also the publications by Anthony Robson. In there also you have a pediatric ERG protocol. And
Thank you. So thank you so
So
much, sir.
only
and
thing
for
is
all
that
the
the pigmentation of Caucasian is different from pigmentation of South Indians and North Indians. So there will be some variation because of that.
Exactly, as sir rightly mentioned, when you buy a machine, it's better you have your own normative data. Fine. So thank you so much. I'll be showing a couple of case examples to emphasize the clinical utility and the importance of fulfilled ERG. So like fulfilled ERG is the mass response of the retina to luminance stimulus. This word is important, okay, because in the other ERG may be using the different patterns. So once you stimulate the retina, so there will be biochemical and ionic changes in the photoreceptor and RPE, which generates electric potential, which is recorded as fulfilled ERG. This is a response from the entire retina. So I'll just take you through some of the case examples where there is some uncertainty about what's happening, what is intended, and what is required. So coming to the night vision problems. So this was a 26-year-old male who presented with night vision problem. So the fundus basically it appeared normal, and OCT, all the layers were intact. It was basically it was normal macular OCT. So when you did the ERG, just look at the darker responses. It's almost like unrecordable, and also the combined responses were diminished. The photopic responses were relatively okay, though they were diminished. So any 26-year-old male presenting recent onset of night vision problem, where structurally things are intact and ERG showing these kind of changes, the next thing I will do is get a serum vitamin A level done. As expected, it was low in this patient. So it doesn't end there. We need to find out why is it low. So on general physical examination, he was malnourished. When we probed, he gave history of dyspepsia, frequent loose stools and all that. He underwent extensive workup to identify the cause for this malabsorption. So finally, he had to go and intestinal biopsy where there were features suggestive of intestinal leukoproteinosis. So the ERG was repeated after 1 week, 1 month and 2 months after receiving an intramuscular dose of vitamin A. So this is the serial ERG monitoring at the presentation. If you just look at the darker responses, by the end of 2 months, it became normal. Okay. So there are some avoidable, treatable cause of night vision. You need to pick it up. So especially the patient who is around 46, if there is a recent, if there is a chronic alcohol, and if you are examining, if you see a tinge of icterus in the sclera, so you need to suspect these kind of changes. If in doubt, get an ERG done. So let me give another example of an abnormal looking retina in an asymptomatic patient. So this patient came for a regular checkup. He was totally asymptomatic. When he saw that my fellow brought this case, sir, patient is symptomatic, I can see so many flex like she said there are multiple exudates in the retina. Then I told they're not exudates, they're flex. And the vision was 6, 6 and 6. OCT again, it was normal, all the layers were intact. So this is the ERG. ERG was also normal. So basically this is a benign flex retina. Okay, you need not do anything. So it's a recessive disorder. So one more patient with similar, not so much of flex, but there were some similar deposits. Vision is again 6, 6 and 6, but this patient had night vision problem. So the first patient was asymptomatic. OCT was again normal. Just if you look at the full-field ERG, so there was an unrecordable 0.01 response, and the combined response, if you carefully observe, the A wave is forming, the B wave is supposed to go like this, but it's not even reaching the baseline, it's getting terminated here itself. So this is the classical electronegative ERG, what we get. So if there is any problem with the inner retina, either in terms of vascular or transmission defects, like bipolar transmission, or if the patient has a CRO, for example, where outer retina is intact, the inner retina is not functioning. So basically you need to think of condition where there is outer retina is intact, inner retina is dysfunctional, you get this kind of electronegative ERG. And one of the most common we see in cases of congenital stationary night blindness. So this was a case of fundus albipunctatus, which is a type of CSNB. So just look at these two cases, both had, in fact the first patient, the fundus looked more abnormal, but when you do the ERG, the functionally it is telling a completely different story. So all of us who practice electrophysiology believe in one thing. So whatever the retina, however it may appear structurally, so that doesn't mean that it's functionally behaving the same way. Okay. Fine. There's one more example of a normal looking retina with an unexplained visual symptoms. So this was a 26-year-old female who was recently married, got the husband because she was inattentive to the surroundings, and there was no positive family history. So after examination, vision, we still don't know what she was giving very variable response, and everything was normal, anterior segment, posterior segment. This is the OCT. I'm showing all the cross sections. It is absolutely normal. There is no defect in any of the cross section in the star scan in both the eyes. Again, the autofluorescence was normal. So obviously we thought recently married, maybe she's not adjusted and all that. Everyone thought she's malingering. So before labeling any patient as malingering, I always subject them. It's better to subject them to the electrophysiological test. So we did the ERG and this is what we got. So our light adapted responses were unrecordable. So this is a case of achromatopsia. So this is the kind of defect what we see in achromatopsia, the defect which resembles photic retinopathy in the fovea. At least in my experience, saw this kind of thing for the first time where everything was normal. Okay. Fine. So sometimes you see patients who have taken multiple concentration. What's wrong with my eyes? People tell there is something wrong in there, but I'm not able to understand what's wrong. So this is one such patient who was a 25-year-old male who presented with night vision problem, no positive family history again. Vision was 6/9. So color vision was normal, anterior segment was normal. So he was born out of a consanguineous marriage. He had one more younger brother. He told he's fine. We didn't examine him, but and this is his fundus photo. So if you observe closely in the posterior pole, there is a kind of a missile-like reflex. So night vision problem, missile-like reflex. I was pretty sure what I'm dealing with. So this is the autofluorescence. It's pretty okay except for mild peripheral hypoautofluorescence, which I see in some of the myopic patients also. The posterior pole autofluorescence, if you look at, there are some stipple areas of hyperautofluorescence which were seen if you observe carefully, just along the arcades. So OCT showed some kind of a peripheral static changes. So mesophenomenon, some static changes, I thought, okay, maybe CSNB variant or maybe a mild variant of retinosclerosis, all that I was thinking. And I was expecting an electronegative ERG. So this is what I got. So dark adapted responses are grossly diminished and delayed. The light adapted responses had a funny kind of a thing. So my mentor, Professor Gramander, always told, if the dark adapted 3-0 ERG and light adapted 3 ERG, if they look similar morphology, we should suspect something. I'll tell what is that. So we thought of going for some other extended protocols, which Parveen Naiman is going to talk on our talk. So we stimulated the long and medium wavelength cones. So using the green background stimulating with the orange light, it was unrecordable. But when it simulated the short wavelength cones, there was an enhanced response. So basically this is a case of enhanced S-cone syndromes. To conclude, I would would like to say the electrophysiology is an important tool to aid the diagnosis in various disease, but it should always be followed by clinical correlation. If we are suspecting retinal dystrophies, additional genetic information might also add. So thank you so much. We have 4 minutes for discussion. Any questions? Yes, I think now I'll invite Parveen ma'am to give a talk on extended protocols. And she'll also be covering the multifocal ERG and the pattern ERG.
Do you have any questions to Puran? Yeah, Deepika, go.
I was just wondering about the acromegalia case which you had. So how do we correlate the patient complaints of not seeing surroundings with the reaction?
No, that's what I was telling. When I mentioned the visual acuity, she was giving variable response. Sometimes she used to tell whatever she feels. I can't see, and all. We are not able to understand the symptoms. That's why everyone thought she's not happy with marriage, she's remembering and all that.
Okay.
Their symptoms are not leading to any of the diagnosis except electrophysiological test which I showed. Nothing was conclusive. The history, anything.
Okay, thanks.
The only interesting thing which I saw, I think they all must have seen that OCT was absolutely normal. In any echometopsy, if you look at all the cross-section and all, there will be some defect. So in fact, when I shared this case with Professor Graham, he told, look at all the section, there must be some change, but it was not there. Absolutely normal. So that is something new which I saw in this case.
I also have one question like that. I was very sure OCT will show the change, but everything else is sitting there. But maybe it will come after some time.
Maybe it will.
Okay, good. Good morning, everyone. I thank Dr. Purnachandra for setting up this electrophysiology instruction course and bring us all together to learn more about electrophysiology, and it's very nice to see so many of you are here to do this learning journey with us. So Dr. Purnachandra, Dr. Tapas and ma'am have all spoken about fulfilled DRG. So these are the basic 6 protocols which have been set up by the ISF, that whenever you try to do electrophysiology to reach a diagnosis, these 6 protocols must be taken and done for every patient. What I am talking of is something which you can do beyond that to establish a diagnosis. So this is probably the first time that I'm sharing my results on this extended protocol. So I'll just go a little slow and maybe take one example at each time. There are many more extended ways of doing the ARG as ma'am had discussed, but I'm going to talk about these 4 because they have now been set up and standards for these have been given by the ISF. So the first one is ISF Extended ERG Protocol for Dark Adapted Red Flash. So as the name suggests, it is done in the dark adapted condition and it is done using a red flash. So when we do our scotopic ERGs, again this protocol is done along with those scotopic ERGs. So what is the technique? The basic principle is that this is, as I said, this is done along with the fulfilled DRG. The basic thing is the dark adapted first wave which is used is 0.01. So after that, if you use a strength of 0.3 and with a red flash, with the same amount of dark adaptation, that is 20 minutes, that is the protocol. Actually, you don't need to remember this because most of the machines will come with this set protocol, but you need to know where to apply it and how to use it. So what happens is that when you use this typical protocol, this is the kind of response that you get. Somehow the figures are taking a little time to come up. So this is the kind of response that you get. Yeah. So what this specific type of stimulation does is it splits the, is there a pointer here? So it splits the B wave, which we normally get in a scotopic dim flash. It splits it into an X wave and a B wave. Normally when you see a scotopic dim flash response, we all know that the first response has only this B wave, right? But when you give a red flash and a slightly higher flash intensity, Now you are getting this A wave, but you are getting an X wave and a B wave as well. So what is the importance of this? We all know that when you do a dark adapted scotopic combined response, combined word means it comes from the cones and the rods. As ma'am said, that scotopic responses means A wave coming from predominantly rods, and photopic means A wave coming predominantly from the cones. But if you do this, so we don't know how much is coming from the cones, how much is coming from the rods. A combined response will have both rods and cones responding, but in this way we are able to split the two. So if you have diseases like cone dystrophy, vitamin A deficiency affects the rods first, cone dystrophy affects the cones predominantly. So if you do this kind of a stimulus, it will show you if the X wave is gone, means the cones are gone. If the B wave is gone, means the rods are gone. So in the combined response, you are able to get two different waves which are telling you whether the rods are predominantly involved or the cones. So this is a normal ERG. You can see this is what I'm talking about. This is the combined response. The combined response here is having, this is the A wave and this is the B wave, and this is coming both from the rods and cones. Now if you see the same thing, this is the normal response, this is the X wave and this is the B wave. X wave comes from the cones and B wave comes from the rods. So if you are having a patient of cone dystrophy, this X wave will be absent. If you are having a patient with vitamin A deficiency, the B wave will be absent and the X wave will be present. So this is what I'm going to show you. This is a patient of cone dystrophy. You can see in the combined response the B wave is reduced, but some response is coming. Here photopics are totally absent, so you don't know whether some amount of cones are there or not. But if you do a combined red flash ERG here, you can see that X wave is gone completely and this has only a B wave. So you know it is the cones which are affected and you have your diagnosis. This is another example. You can see again the cones are gone and actually the rods are supernormal. So, but if you see your if you see this, the flicker ERG also, this is another case actually. This is a case of vitamin A deficiency. You can see here that some response is present. There is a little noisy, patient was not very cooperative. Some response is present, but if you see the cones are very nice. Again, repeatability is an issue because patient is not very cooperative, but still you can see responses are very good. But if you see the red flash dark adapted ERG, the B wave is gone. So vitamin A deficiency affects the rods and not the cones. X wave is so beautifully picked up, but the B wave is not there. So our diagnosis was vitamin A deficiency. We got the vitamin A levels done, and the vitamin A assay which was done, it showed that normal range is between 30 to 80 microgram per deciliter, and it was only 15. Patient was prescribed oral vitamin A supplement. The patient is yet to come for a follow-up. I'm sure as Dr. Purnachandra showed in his slide, the responses would be better. Then we have the second one, which is the photopic on and off ERG. Dr. Purnachandra mentioned and told us that we have something called congenital stationary night blindness, and if you know, we have two types, the complete and incomplete. The complete type affects the on bipolar pathway, and the incomplete affects both the on and off bipolar pathway. The importance is that they are caused by different genes. So if you know which pathway is involved, you can actually do a targeted gene identification to look for those genes. So this is a response to a very long duration of stimulus. So here the stimulus duration is increased to about almost 150 to 200, when the normal is usually duration is almost 5. So this is a very increased duration. And when you have this kind of a long duration, and as name suggests, it is done under photopic condition, your response is something like this. This is the long duration response. It has three components. One is the A wave, then is the B wave, and there is a third wave called the B wave. So this complex of A and B wave comes from the on bipolar pathway, and this complex comes from the off bipolar pathway. So till now the ERGs were telling us whether it is the cones, the photoreceptors or the bipolar cells. extended protocol is telling us whether it is the on bipolar cells or the off bipolar cells. So this is the origin. A wave is known to come from the photoreceptor cells, B wave from the on bipolar pathway, and D wave from the off bipolar pathway. And when you measure, this is the amplitude of the A wave, this is the amplitude of the B wave, and the amplitude of B wave comes from the offset of the stimulus. So this is an example of congenital stationary night blindness. We all know that here very dim responses are almost non-recordable scotopic low flash. This is a typical negative waveform which is seen in the combined response, and this is almost near normal photopic. So from this itself you can make a diagnosis. This is CSNB, but you may not be able to tell whether it is incomplete or complete CSNB. Now I would want you to concentrate on this wave because this is totally in comparison to the example which I showed you here. So you can see A wave is present. A wave is present here, which is normal. The B wave is absent. And if you see the B wave here, it is present. So if the B wave is absent, it is complete CSNB. Okay? If the B wave is absent, it is incomplete CSNB. So you don't have to use anything. You don't have to use separate parameters on full field ERG. You do this one protocol. B wave absent, it is complete. B wave absent, it is incomplete. And it is very highly reproducible. So with this is the third protocol, which is the S-cone, and which I think Dr. Purnachandra mentioned it. So this is mostly used for diagnosis of the S-cones. So this is an example. So now we know that there are three types of cones in the human eye, which is the L, M, and S cones. Normally S-cones form only 10% of these cones. So most of the photopic responses comes from the L and M cones. In enhanced S-cones, there is no L or M cones, so the only response that you get is from the S cones. S cones fire almost like rods, which is why, as Dr. Purnachandra mentioned, the scotopic responses and photopic responses look identical. So this is how it may look like clinically, and again the foveal species subtle is present on the OCT, and if you do L and M cones, this is the full field ERG where you see the scotopic combined is looking identical to the photopic combined. So this is the diagnosis, and you can do an S-cone enhanced ERG to see that no firing is happening from the L and M cones, and the only response is from the S cones. This is another example, and this is again another example. You can see incomplete that it is the another case of S-cone. And you can see that your L and M cones are extinguished, S cones are present. This is another example just to give you in comparison. You have rod cone dystrophy, and you see both L, M, S, everything is extinguished. So this is how it looks in comparison. We come now next to the PHNR, which is the photopic negative response, and it is importance of this comes from the ganglion cells, and it is highly very sensitive in cases of glaucoma, optic atrophy, central retinal artery occlusion, and diabetic retinopathy. So we can do it on a visible white stimulus as well, but you can do it with a red flash on a rod saturating short blue background, which is what has been described as a standard by ICEF for this extended protocol. And this is how it looks like after your photopic response of A wave, B wave. You generally have this I wave, and then you have this negative wave coming down, which is the PHNR, and you can measure the amplitude from the trough of PHNR to the peak of B wave or to the baseline. Either way, you can do it, and I'll just finish with one example here, which is, this is normal, this is mild NPDR, this is PDR. We have published this, so you can go through the article as well. It is in Documenta. So this is how it looks with in a normal patient. You can see the negative waveform is seen well, but if you see a mild NPDR, already this negative waveform is smaller, and in PDR it is almost extinguished. So much more things are possible. The applications of ERG can be really extended into our regular work, and they can help us in many ways. It is not only an experimental tool. Thank you.
So thank you so much, ma'am. Thank you so much for a wonderful lecture. So I have one question. Do you prefer doing extended protocol in all patients who walks into your electrophysiology department?
No, we don't do that. It is very difficult because already it takes time, and so what when we suspect from our full field DRG, that is done first. So when we suspect a particular disease, then you know that rods and cones are subnormal. So any something like rod cone dystrophy or cone dystrophy or vitamin A deficiency, those things we do a red flash extended protocol. In any case of congenital stationary night blindness, or whenever you see a negative waveform and you are suspecting CSND, we do an on-off protocol to find out what kind of CSND. So that's how it works. So maybe when we are ordering based on the clinical findings, if we have like a patient with myctalopia and we don't really see obvious RP, then your diagnosis will be either vitamin deficiency or CSND, then that is what the test will order. But if you see clinically something looking like enhanced response syndrome with the very typical patterns and just some myctalopia, then you will possibly say that do your flash and simultaneously please do the enhanced response. So some clue we can give during the clinical advice, and it's always very important in any test, whether it is X-ray or CT scan, you must put your clinical diagnosis because that will give a clue to the electrophysiologist, is my test coming normally, that or should I do an extended protocol before the patient again goes back to you, then again goes there. So good technicians, they will understand. Yes, exactly, that's what I was going to say. So earlier what used to happen is, they used to, after ERG, they would come back to me, the patients. I would see them now and suspecting S-cone, I would send them back for it. But now they have, my optometrists, they become so smart, they know this is S-cone. They will LNM cone, they will do and send.
Here on the electrophysiology, it's very tricky to have a very good technician. As Ma'am rightly pointed out, they themselves decide once they think something is normal.
So that is also not true. Final interpretation has to be done by you, but they can always do the test.
But it advised lot of time, the patient coming in, going back, and this dark adapting again. And like India, like they come one day, they want everything under.
It's like, if you send the corneal sample and you say clinically I'm suspecting acanthamida, then we will do that stain simultaneously, or I'm suspecting mycalia. So it's a learning curve both ways. Now when they are smarter, they will pick up CSND immediately on the negative wave. They will do it, they will do on-off and send. Long duration they will do it.
Are taken in all together in the context. So usually having the fundus photo and OCT along with the ERG helps. So when we order all these things together, then sometimes the technician also has, usually they have a look at the fundus, and sometimes you might not be expecting they would have done that extra test also. So that's why.
But it works both ways. You have to make sure that you do the final interpretation, and always tell them you do the test, but you will not write the diagnosis. The diagnosis will be written by the clinician.
That's a very important point. Are there any questions from the audience? You have 1 minute. Okay, fine. So, Deepika.
So I had this one question regarding enhanced S-cone syndrome. So when you do a full field ERG, and I suspect that it is enhanced S-cones, I'm already getting some information about L and M cones from the photopic responses which I see. So when I do the S-cone ERG, do I always have to do M and L cones as well? Because sometimes some forms of responses...
Actually, this is enhanced S-cone is one disease where you can, a simple full field ERG can tell you this is NR2E2D genetic disorder. So it is absolutely diagnostic. You don't need to. But you can specifically sometimes if you have something called like a rod monochromacy and you want to distinguish it from S-enhanced cone, in which case, even then full field ERG will give you the information because photopic responses will be totally extinguished vis-a-vis an S-cone. But it is just one more test to establish the diagnosis. But yes, full field ERG is absolutely diagnostic in enhanced S-cone.
So only two things, like on this enhanced S-cone and KCNV2 mutation where ERG is diagnostic. You need not even go for the genetic testing. You can say it is this. Thank you so much, ma'am. I think...
So one more, the next talk, I think Dr. Neha was not able to join us. So
thank you so much for agreeing to cover this topic.
So this is multifocal ERG. I'll speak to you on this. Most important thing to remember is before you do multifocal ERG, you have to do a full field ERG. You have to establish what the full field ERG looks like, and then you go for it. You do not do only multifocal ERG for a patient.
important. So this is before I start the estimate that. So it was initially developed by Sutter et al. And it is basically records many focal retinal responses simultaneously over a brief period of time. And the difference between full field and multifocal ARG is that both rods and cones are tested because you are doing photopic and scotopic. Multifocal ARG, you are doing it under photopic conditions, only the cones are detected. So full field ARG is electrical activity of the entire retina. Multifocal is only the multiple retinal responses from different locations. And actually full field ARG is a true retinal response. As ma'am said, you give the stimulus and you get a response and we measure it. But multifocal ARG is not like that. It undergoes a lot of mathematical extraction. The kind of responses that you get are actually a mathematical extraction and not really the true responses. So this is about 40 to 50 degree of central retina that is measured. This is what it in nutshell looks like. This is the, you have to use, we are using a Retinal electrode because it gives you good stable configuration. And going into it one by one, the fixation is very important. Good visual acuity, good fixation. Anything less than 660, your multifocal ARG is useless. It will not give you any response, and whatever you are getting probably just noise. So you have to monitor fixation. So most of the machines come with an automatic fixation monitors, and if that is not working, you will most of all give up multifocal ARG because little bit change in fixation, and if you are not able to monitor it, it can change the multifocal ARG completely. So this is because patient is looking at a pattern, patient has to be corrected for the refractive error. This is what the stimulus looks like. As I said, we are doing under photopic conditions, so it is cone-driven, central 40 to 50 degree, and this is something called a pseudo-random sequence because it is looks like random, but it is made sure by the computerized system as to which way it happens, and it is basically most important is that the illumination across at any period of time should not change when this pattern is changing. It will give us response. I think something is the problem with the computer which is lagging. Do you have a computer set up that side? Is there video there?
On that side, the system is not there.
But went up. वो वहाँ से यहाँ ले आएंगे थोड़ा सा उधर से ले आएंगे देखते हैं Okay, so this is the stimulus, and the stimulus basically does a pseudo-random sequence, and it makes sure that only 50% are illuminated at one particular period of time, and there is no change in the contrast at any time. So multifocal ARG gives us interpretation in form of trace errors or in form of topographical maps. It is best to interpret the trace errors and not the topographical maps. You can have a 37 MFARG 61, 103, 241 depending on the various stimuli which are, number of stimuli which are given to the patient. As obviously understandable, 37 is faster because less stimuli are there, but the resolution is lesser vis-a-vis the 241 where the recording time can be very high, patient cooperation is necessary, and but the resolution is very good. So this is another way they analyze the MFARG can give you various, the foveal areas affected or the perifoveal areas affected or the parafoveal areas affected. If the various wings are involved, it can show you on that. So this can be very useful because the visual map is given, but as I said, the trace error is what should be analyzed. looking at the components, you do have an A wave and a B wave even in the multifocal ERG waveforms, but this is not a true A and B, but a mathematical abstraction. For all practical purposes, we believe that N1, P1, N2 correspond to the A and B, N1 and B is the P1, and N1 is considered to be from the cone photoreceptors and P1 from the cone bipolar cells. So having understood this, look at the distribution. So now on the left-hand side, you can see this is central retina, which is affected because you can see that here the central waveforms are more affected as compared to peripheral. If you look at the second one, the central very little response is present and the peripheral is extinguished, which can happen in patients with RP. And the third is the generalized reduction and all central and peripheral responses are gone. Localized reduction, you can see the inferior area is gone, superior is present, so it gives you the distribution. This kind of a thing can happen in cases of vein occlusion, the branch focal vein occlusion. So the clinical applications, the most important is a localized iridomacular degeneration. Now you can see the fundus in both the eyes almost looks similar. The fundus on the left-hand side is near normal and only a light apical reflex. On the right you have only a few yellow flecks which is seen. ERG, full-field ERG almost looks okay. But if you see the multifocal ERG is completely extinguished, and in this patient it is only the central area which is affected. So this is an early stage of a cone rod dystrophy, but you can see even though full-field ERG is not showing the changes because it is early stage, but the multifocal gives you an indication that we are looking at a more generalized kind of defect. As I mentioned, and ma'am also correctly mentioned that as we are going to do gene therapy in patients with RP, it's very difficult to follow them up with a full-field ERG because anyway the whole ERG is going to be extinguished. But a residual response, which may increase in response to your gene therapy, is what is going to be important in cases of RP. So this is even in diseases, acquired conditions like CACR, we can have multifocal ERG, and looking at the drug response is another most important thing. I'll just cover this quickly. This is the most important thing is hydroxychloroquine toxicity. Multifocal ERG is one of the advised by the American Academy of Ophthalmology that this test must be done to follow up patients with HCQ toxicity. You can see that in HCQ toxicity, very subtle changes are only seen in the foveal area, and a full-field ERG is normal, and there is no way you can detect it on full-field ERG. So multifocal ERG is what shows you the central area, which is decreased. Another test which is advised by American Academy of Ophthalmology for HCQ toxicity follow-up is SDOCT and perimetry. Chloroquine toxicity can be more affecting on the macula as compared to HCQ toxicity, and as I said, NFERG, FAF, SDOCT and fields are the ones which are considered to be the tests that you must do. Risk factors are any dose more than 5 mg per kg body weight for more than 5 years. Patients must undergo multifocal ERG once in a year at least, and if possible at baseline as well. If you do, it is useful. Other drugs can also give you an indication on multifocal ERG. A lot of work has been done in diabetic retinopathy. As I showed you in my previous talk, that you need not have multifocal ERG to show that if your electrophysiological tests are reduced. Even full-field ERG is reduced. PHNR, which is recorded on full-field ERG, is also reduced. But multifocal ERG can actually give a selective reduction. So wherever you have a patch of hard exudates or a patch of dropping blood hemorrhages, those particular areas can show you a multifocal decrease in corresponding areas of multifocal ERG. You can see this figure is a patient with diabetes but no diabetic retinopathy. But you see the multifocal ERG is almost just like a noise, and no particular waveforms are visible. So again, the same thing in diabetic eyes. This can be very useful if you do it. The caveat is that you must do a full-field ERG along with it and make sure the noises are taken care of. Just a few slides on pattern ERG. The most important thing is, again, since it is a response to a pattern, so your refractive error should be in place. Vision of the patient should be good. If the patient's vision is not good, whether it is a maculopathy or it is a nerve disorder, pattern ERG will be non-recorded. audible. And because we are looking at a pattern, we don't want the patient to be dilated as well. So this pattern ERG has two components, P50 and N95 is what we are looking at. P50 is luminance dependent, so it reflects the macular function. N95 is contrast dependent, so it reflects the ganglion cell function. So if ERG in response, this differentiation between the N95 and P50 is what helps you diagnose your condition. So this is one example. If you have a normal ERG and abnormal PERG, it is the maculopathy that you are looking at. And abnormal PERG, only a decrease in P50. If you have abnormal ERG and decreased P50, that means it's a generalized retinopathy. And if it is extinguished, definitely it is the poor macular function which can give rise to this. But if you have a normal ERG, abnormal VP, and a reduced N95, then it is a optic nerve disease. So just to compare the two, P50 is normal in optic nerve dysfunction. In macular disease, it is reflected. N95 amplitude is what gives you the optic nerve dysfunction. Usually N95 latency and P50 latency is not what we talk of. We usually talk of the amplitudes. Just to give you an example, acute stage of optic neuritis, because the vision is very low, PERG will be totally unrecordable. By 3 weeks, as the vision starts improving, PERG starts coming up, but you can see P50 comes to normal, N95 does not come to normal, so it is decreased. This is another patient, right eye optic neuritis. You can see here the left eye is normal N95 component, but the right eye there is no N95. So this is suggestive of optic nerve disease. So you correlate with the pattern VP and arrive at diagnosis of optic nerve disorders in pattern ERG. Thank you for your time listening.
So thank you so much, ma'am. So I have just one question for you regarding multifocal ERG. In my practice, the commonest indication for my MFERG is all the rheumatologists, they refer the patient for HCT toxicity. I also strongly believe the full-field ERG has to be done whenever the multifocal ERG.
Come on the dash.
Sure, item. So do you also prefer doing the full-field ERG when you screen for HCT toxicity?
So at baseline, we definitely do once full-field ERG. But suppose after that the patient is now coming for a 6-monthly follow-up, then if you want, you can do a direct MFERG also once you have documented that your full-field ERG is normal. But I had an example, one of the patients whom we mentioned that there are early changes because of HCQ. So the patient was withdrawn of HCQ and started on steroids. Patient developed CSCR, in which case I had to do a full-field ERG to see whether it had affected wider area of the retina, and the MFERG responses are not just because of that affection. So then you have to repeat a full-field ERG as well.
It's a very valid point.
We don't do that. We do only the multifocal ERG unless there's something in there.
So
We do television.
okay. Fine. So we have a couple of interesting cases to be presented by Dr. Sharina and Dr. Deepika. So Dr. Sharina is a consultant retinal surgeon at Narayan Vidyalaya with area of interest include electrophysiology and inherited retinal dystrophy. She'll be presenting one interesting case. Over to you, Sharina.
Good morning, everyone. I'll start my case presentation. So this case is of a 14-year-old Asian male who came to us with decreased vision for both distance and near in the right eye after an episode of fever. He did not give any history of trauma, night blindness, or photophobia. There was no significant family history. On examination, the vision in the right eye was 660 and N36, whereas left eye was 66 parts and N6. On the color vision charts in the right eye, he was unable to identify any plates. Left eye was mildly subnormal. The lens was clear. On fundus examination, he had a bullseye maculopathy in the right eye, and left eye also had some mild RP changes at the fovea. OCT macula of the right eye, as you can see, shows foveal thinning with outer retinal layer lost in the subfoveal area, and left eye had a focal ellipsoid zone defect in the juxtafoveal region. Fundus autofluorescence in the right eye again showed a bullseye appearance. Left eye had some mild hyperfluorescence defects. ERG was done, which showed grossly abnormal photopic responses in the right eye, whereas left eye was almost normal. A systemic evaluation was done because he had a history of fever, which was there before he presented with his decreased vision, the evaluation did not show any features of any infection or inflammation. He was given prophylactic antivirals and low-dose steroids, following which also there was no change in his vision. We followed the patient up to 6 months. Even after that, there was no change in the patient's features. So we went ahead and did a genetic evaluation. We did a whole exome sequencing, which showed heterozygous missense mutation of unknown significance in 4 genes, as mentioned. In addition, 1 mutation of unknown significance in CRH gene was also noted. To summarize, so this was a case of a 14-year-old Asian male with unilateral decreased vision with bullseye maculopathy in that eye, triggered after a viral infection. He had asymmetric diminished light adapted responses in the right eye, more than the left eye, and 5 mutations were noted on whole exome sequencing. So the question is whether this case can be called as a unilateral or asymmetric cone dysfunction. Do our experts here have any experience of similar cases? And if it's a unilateral or asymmetric cone dysfunction, what can be the cause of it, like an incomplete penetrance or a mutation in an epigenetic regulatory focus? Thank you.
To me it looked asymmetric because I think the left eye is also showing some lesion that's not normal, and I would like to see the parents and maybe get the ERG of the parents.
We had done an ERG for the parents and the one sibling. Everything was normal, and there was no history of any visual problems also.
Right. So then it could be just a mutation. Now if we look at those 5 genes that we got, is there any one of them which is fitting into this type of early onset pediatric age cone dysfunction?
Only CRX is known to have cone dysfunction. Others are all related to rod dystrophies. But there have been some anecdotal case reports which have been reported, but nobody has done a genetic correlation of the phenotype.
Yeah. So if we say CRX, then maybe we can get the CRX done for the parents, and see is it passing on from that generation, and keeping follow up and see whether like out of these 5, to pick up one, and since he's not falling into ushers or PD6, you said CRX is more likely, then maybe the parents evaluation can be done for CRX.
The father is CRX is normal. Father is having CRX. That's why I still had CRX. So initially I thought maybe CRX.
So the father is
having CRX. So rest of the mutations were not in none of the family members. Only father had CRX.
So now do we say that this is a CRX mutation?
No.
Can you just show me you have an autofluorescence?
Yes, I don't know what that is. Father has CRX. But
I don't think it's really asymmetrical, number one. It has a lesion which is coming up, and 14-year-old, it is a disease in evolution. Most likely by the time the child grows up, you will have a full-fledged bullseye in the other eye also, number one. Number two, I think whenever we do autofluorescence, in addition to the macula, we need to see the periphery. Do you have a peripheral autofluorescence? No. So something must be happening in the periphery, and autofluorescence will be the first thing to pick it up. So, and here also, if you see, these changes are not, go to the OCT. Yeah, if you see, that is the left eye OCT. I'm not sure whether this is the foveal scan, but this definitely, there is a loss of ellipsoid in a much extended area. So it's a symmetrical disease. It's just that one eye will be more affected than the other. What was the vision in the left eye?
Sorry, no?
Vision in the left eye? Yeah, that's because probably some island is there. And if I see the fundus, this is the obvious photograph, right?
Yes, ma'am.
There is a mild arterial granularity in the periphery, and there's a mild arterial attenuation. I would put it as one of the cone rod dystrophies. It will sooner or later affect the rods also. I feel we need to follow it up. There's a mild disc pallor, there's a arterial attenuation, peripheral mild granularity is present. This will be a most likely also. And you show your peripheral fulfilled ERG? Let's see the fulfilled ERG. Fulfilled ERG, I don't think the rods are normal. Aren't the rods also subnormal? The scotopic combined response, I think the B wave is subnormal, the A wave is also looking lesser. So I don't think we are looking at a cone. It must be an early cone rod. And by the time you see the progress of disease, follow up the patient, repeat ERG at 1 year, 2 years, it will go into cone rod.
very thinning corresponding to that area. So this again points towards probably both the eyes are affected, and definitely if you follow them up for 4 or 5 years, we will be more clear.
Fine. Thank you so much, Sharna, for that interesting case, and thanks panelists for the inputs. Now over to Dr. Deepika C. Parmeshwarappa. She will be presenting an interesting case. She is a consultant retinal surgeon at L.V. Prasad Eye Hospital, and her areas of interest include electrophysiology and linear retinal dystrophies. Over to you, Dr. Deepika.
Thank you, Dr. Puna. Quickly, I'll just go towards the case. My patient is a 27-year-old male, IT professional, presented with diminution of distance vision since childhood. It is progressive and also night vision difficulties. There were no other history which was contributory. There was no history of consanguineous marriage as well. So the 3-generation pedigree showed that only grandfather had some defective vision, but the cause was not evaluated, and the grandfather had a history of consanguineous marriage. This is the fundus photograph where we are seeing that the right eye vision is 20/100, left eye 20/160. There is symmetrical presentation in both eyes. The prominent features which appear over here are subretinal yellow deposits, yellow to whitish deposits along the major vascular arcades. At the center of the macula, we can see that there is atrophy, scarring, and pigments. Grossly optic disc and vessels appear normal. The autofluorescence is correlating to what we are seeing clinically. It is showing some hyperautofluorescence along the arcades and also inside the macula with hyper and hypoautofluorescence. Center hypoautofluorescence corresponding to the atrophy and pigments which we are seeing. The OCT in both eyes is again showing what retinoschisis involving the outer nuclear and outer plexiform layer, and the subretinal scar which is seen as subretinal hyperreflectivity over here. So with respect to the symptoms, how patient presented and all these 3 investigations, what we are looking at. So there are 3 phenotypically similar looking fundus which we are thinking of here. Is it congenital retinoschisis because it is affected male prominent foveal schisis, and also some not exactly like, but there can be a peripheral retinoschisis like changes. The second one over here is autosomal recessive dystrophinopathy because of the subretinal yellow deposits along arcades and foveal retinoschisis. Enhanced cone syndrome because the patient has myopia. There are mid-peripheral along arcades, yellow to whitish pigmentary changes, and foveal retinoschisis. So how do we take conclusive diagnosis? Of course, the electrophysiology will help us. This is the full field ERG of the patient, which shows that there is definite reduction in the isolated rod response and combined rod cone response. That is, the amplitude of the B wave is reduced, and also the A wave. Oscillatory potentials are present. If you see the photopic 3 and photopic 3 flicker, as we were discussing in the previous session also, that there is a similar looking of scotopic and photopic ERGs. So is it enhanced cone syndrome? So what we have to look for this is that in the isolated rod response, we are seeing the B wave, which is not seen usually in enhanced cone syndrome. So to confirm that, S-cone protocol is always needed. So this is the S-cone ERG, which shows that waveforms are affected in the S-cone also, and we are not seeing the enhanced waveform in the S-cone, thereby we are ruling out enhanced S-cone syndrome. And with respect to the retinoschisis, congenital retinoschisis, we're not seeing an electronegative B wave, so that is also ruled out. So the narrowed down diagnosis is dystrophinopathy. To confirm that an electrooculogram was done. Here is the report which shows that the circuits are good, a good waveform, sinusoidal wave pattern is there. And both the eyes, there is reduction in the light peak, which is showing that there is reduction in the light peak versus dark depth ratio, which is quite abnormal over here. So with all the fundus features and the electrophysiological test, the most provisional diagnosis which we can come to the diagnosis is autosomal recessive dystrophinopathy. Of course, we have to do the genetic confirmation of the BEST1 gene to confirm this. My take-home message from this case is that electrophysiology can appropriately distinguish a phenotypically similar looking fundus, and a combination of electrophysiological tests is necessary for a conclusive diagnosis. Thank you.
So thank you, Deepika. Such an interesting case. Of course, definitely looks like a dystrophin related thing. We always look at the dominant and the recessive one, but there is one more called compound heterozygous mutation. Those can have these kind of typical features. Just keep us updated once you do the genetic testing.
Yes.
Any comments, ma'am?
So I don't go back to the ERG. I think the phenotypic presentation was quite typical of autosomal recessive dystrophinopathy. Even the ERG, if you see, I don't think if you go back to autofluorescence, this kind of autofluorescence also, the stereo pole, that is more suggestive of probably AID. So phenotypically, I think my first suspicion would be autosomal recessive dystrophy.
So, thank you, Deepika. So before we conclude, I would like to invite comments from the students.
Actually, do you have still peripheral pictures?
Sorry, Dr.
Yeah, so the whitening that we see in the periphery, sometimes seen in this autosomal recessive dystrophinopathy, this is called as DOLO, diffuse outer layer opacification. So, yeah, so these, those were the group of disorders. If you take OCT in that area, you will see that thickening extending beyond the area what you are seeing clinically, and they can correspond with the areas of whitening. And has been told as DOLO, diffuse outer retinal layer opacification.
Thank you, Deepika.
Yeah, fantastic presentation by all the experts and good case discussion also. My only question coming from a medical college background, we have multi-specialty rheumatology, dermatology and pediatric departments which require these definitely. Should we go and buy these instrument of ERG, or should we keep referring to the nearest center possible and keep reading and keeping the charts for exams in OSCE?
I think it will depend on the load of the patients. If that medical college has a good rheumatologist who is giving a lot of, these drugs, or they have a good epilepsy center where ligabetrin is given, and they also look at a lot of cerebral palsy, then definitely it makes sense. So I think it directly depends on the commercial thing. Right?
Yes, ma'am. You have to fight with the corneal surgeon and the phacosurgeons for all the
So the type of machine you buy will also depend on what are the questions you want to answer. Sometimes you can buy some module, work on that, earn the money, then buy the next module from the same company. So they do sell modular parts also. But definitely it's a big medical college and you have enough patients. You can become the reference center for other people to send to medical college for.
We have one corporate hospital as well as a medical college hospital. And the thing is, the module pattern would be better for us to upgrade a little later. Thank you.
Sometimes you can have funds from okay, it becomes like a central facility that it doesn't belong to ophthalmology, and then neurologists can also pinch in that okay, it belongs to neurology, and because they have to do the
Neurologists already have bought a VEP